Today I will be talking about scanning the spinal cord, in particular C, T, and L spine. But before I do that, I want to mention 4 common aspects I saw for myself while studying for this particular topic. And the first aspect that common for all of them is that we use the same exact coil. It is dedicated phased array spine coil. And we position the patient always on the back, supine, and head first. The second aspect I notice is that when we're planning sagittal slices on the coronal plane, we have the same exact slice coverage. It's from transverse process to the transverse process. In other words, we have to get all that bony structure of the spine in all 3 cases. For all 3 of them, C, T, and L spine, we will be eliminating the motion artifacts of people breathing or digestive movement. We will be using saturation band. And the fourth aspect is that we usually do not plan coronal view. However, the only time we do use coronal is when we do the scoliosis diagnosis. Now let's go in detail with all 3 of them, C, T, and L spine scans. Now, first of all, let's talk about preparing the scan room for the next patient. I have a patient that comes, I have to scan his neck, and that will fall under C spine. So first of all, I will check the order, make sure everything is in place, and also it will help me to see, okay, this is his diagnosis. We're scanning C spine, and I know exactly what scanner to use, that coil to use with the scanner. It is a dedicated phased array spine coil. So I will demetalize myself in the zone 3 before I'm going to zone 4. I make sure none of the loose metal objects or any electronic devices on my body. No watch, no phone, no credit cards, no keys, nothing like that. After being successful with this part, I will go and prepare the coil. I will wipe the coil clean, make sure that the coil is plugged in, as well as the sheets and the pillowcases are brand new, clean for the new patient. Also, all the surfaces that I touch or my previous patient touched will be also cleaned by me. It includes the scanning table, doorknobs, the locker areas where the people put their belongings, all kinds of things. Then I will be ready for my patient. For that, I will be using the very useful technique. I will be using the technique AIEDT, which is we're using for every single patient, not just the spine scanning patient. I will make sure that we go over all the necessary questionnaire about implants, about the surgeries, all kinds of things. And then I will explain the patient that he has to change in the hospital gown, and all his belongings he can be locking into the dedicated locker. If we use contrast, I make sure I check the test of GFR, and it has to be no older than 30 days, as well as the number should be over 30. In some facilities it's required over 50, but in my facility is over 30. So at this point, my injector will be also ready, all clean, disinfected, prepared, and that's it. I can escort patient in the scanning room, because before that I already told him about the procedure, about the details, about timing of it. This is a part of AIEDT, the part called duration. So my patient already went to the bathroom, asked me all the questions, and at this point I will provide the patient with a hearing protection aid, like a nice quality earplugs, as well as I put cushioning around him to protect the patient from burns. And also I'll give him a squeeze ball for him to be able to call me anytime something goes wrong, or the patient suspects that something is going wrong, or he doesn't feel good. Then I make sure my patient lays down on his back, head first. And for the cervical scan, I will also be using the extra part that will help me with a better scan. The anterior bridge attachment will be used for this particular CT scan, because when we lay down, we have some sort of curvature here, and in order to flatten it out, we use that particular attachment just for this particular scan. The way it works, that we only interested in posterior part of the patient all the way to vertebrates. The rest, anterior, we're not interested in it. However, it is very important to eliminate any artifacts that can interfere with getting the good quality image. Those artifacts come from swallowing in our case, because the scan will be about 4 minutes, and it's normal for a patient to swallow from time to time. So we are using saturation band for this particular case. My patient is great. He follows the instructions to lay still without movement. My landmark will be on mid-neck, and the way to find it is to make sure that the chin of the patient is a down position, and from that chin it will be 1 or 2 inches down. That will be my landmark. As usual, I will be running localizer first. It is a low resolution image that takes only 45 seconds, but it's very valuable because it helps me to see if I cover everything right. All the anatomy that is needed is there. So very useful. For sagittal planning, I will be using coronal plane, and all I will be doing with angulation is to run it parallel of the spinal cord. The field of view will be including from pons all the way to T4. As I said, we are going to put saturation band over the esophagus to eliminate swallowing motion artifact. Like I said, the coverage will be from transverse process to transverse process. I will plan axial on sagittal plane. And this one will be angled perpendicular to spinal cord. Coverage will be from C2 to T1. We will see saturation band again. Like I said, we are going to use coronal only if we are working with scoliosis diagnosis. And for that, we'll be using sagittal image because we have to go parallel spinal cord again. This is angulation for it. Again, the slice coverage would be from transverse process to another transverse process. And field of view from pons to T1, it depends on the protocol. Now I have a patient with thoracic spine scan. For that, I go over the same procedure again. First of all, before going back to scan room, zone 4, I demetallize myself, go in the scanning room, cleaning, disinfecting, coil, disinfecting the table, all the surfaces we touched, inside the bore. My linens are new again, pillowcase and sheet is new. My blankets also clean, new, because from the last time it was kind of chilly, and then my previous patient was complaining a little bit, so I brought out awesome blankets. My power injector is ready to go. So I walk out of zone 4 and greet my next patient in the zone 2. So I already checked the order. I know that it's going to be a thoracic scan. So my coil, the same thing, is dedicated phased array spine coil, my best friend. And I already explained everything to the patient. We went over the paperwork, the implants questions. I explained to the patient the duration of the scan, that he has to go to the bathroom before that. He's already went, so everything is fine. He has to change into the hospital gown and lock all his belongings in a dedicated locker. I answered all his questions and we walk in the zone 4. My table is already lowered again. Everything is clean. I provided my patient with hearing protection, with cushioning from burns, and with the emergency squeeze ball, so he feels safer and not alone. I will be always ready to help if he needs it. The patient is positioned supine, head first. We have 2 ways to go about finding the landmark here. One would be counting localizer, and the second one, we will not use the counting localizer. With the counting localizer, we will use the same landmark as we did for C-spine. It is mid-neck, 1 to 2 inches from the chin, that is in down position. If we don't use the counting localizer, our landmark would be in the middle of the sternum, around T4, T5. That just means that each site has their own rules, they do things differently, so it's just up to me to make a note of what they're doing, how they're doing. Okay, so my patient doesn't have scoliosis, so that means I will be running only sagittal and axial. For that, let me start with sagittal. For sagittal, I will use coronal plane, where I can see the spine, and put my slice parallel to the spinal cord. Very easy. Field of view will be from C1 to T12. And like I said, again, the slice coverage will be from transverse process to transverse process. And of course, we do not forget about saturation band, because on the chest, we have the breathing movement, and this will help us to eliminate the moving artifact. Axial slices, I will be planning again on sagittal image. It is very convenient because I can see, I can put the perpendicular angle towards the spinal cord there. That will be my axial cuts. Slice coverage, also pretty straightforward from T1 to T12. We don't want to do more than we need to, because this is a really big area and it will be a long time scan, and we don't want to prolong it longer if it's not necessary. We do see the saturation band on this planning as well. We really need to eliminate that breathing motion artifact. My next patient is with lumbar spine MRI according to his requisition. That's fine. Again, I use exactly the same coil I used for C and T spine. It is the dedicated phased array spine coil. I again demetalize myself before I walk in the zone 4. I have to prepare all the necessary stuff, the power injector if it's necessary, to make sure everything is clean. I wipe inside the bore, the bed, the coil itself. Coil is plugged in. I lowered the table, and I also disinfected all the surfaces we were touching with the previous patient. Then I walk out in the zone 2, greeting my patient and bring him in the zone where, not a scanning zone, zone 3, where I explain to him all the procedure, the duration, that he has to change out of street clothes, and not to worry that his belongings is going to be locked in the locker he's provided, and make sure that he went to the bathroom. If he didn't, please use this opportunity. And we went through all the paperwork. He signed the paperwork. I signed the paperwork. Everything looks great, and we walk into zone 4. He sits on the table. Then I lay him down on the supine position and head first. I ask the patient if the patient is comfortable, if the things I provided to him is working fine, meaning hearing aids, hearing protection aids, earplugs are fitting well, there's no pain, as well as he knows how and in which cases to use the squeeze ball, emergency squeeze ball. So patient doesn't have any questions, and I'm telling him that I will be closing the door behind me, but I'm always there for him, and if something he needs to address, there's a squeeze ball, emergency squeeze ball. I'll be there as soon as he needs me. I'm running localizer. Of course, before that, I make sure I determine my landmark, which is mid-abdomen, 2 to 4 inches above the iliac crest, and then we're set for the scan. I ran localizer. That is a very low resolution image. It takes only 45 seconds, but it gives me a clear picture if everything is positioned right and I'm not clipping anything. This patient as well is not suffering from scoliosis, so I will be running only sagittal and axial planes images. I will use coronal plane to plan my sagittal images because I can see the spinal cord very nicely there, and I put my angulation like parallel to the spinal cord. My slice coverage will be from one transverse process to another transverse process. Field of view will be from T11 to coccyx. I will not forget about my saturation band. It is very important because we have potential artifacts, motion artifacts from patient breathing, and also digestion is going on in that area. So we're planning my saturation band right there. For axial lumbar, I use sagittal plane because I can clearly put the perpendicular angulation towards the spinal cord. Slice coverage will be from T11 all the way to S1. Saturation band will be placed anteriorly. There's one tricky thing here. Some people have one extra lumbar vertebrae, so instead of 5 it will be 6, and we have to be careful counting it right. We should locate ribs, and this way we'll see like, okay, where is the thoracic vertebrae, and then where are the lumbar vertebrae. We have extra scan for this particular case, lumbar axial, that we don't have for any other areas. It's called axial or multi-block. What we do, we need to check the spaces between vertebrae for hernias. The reason we do it is because our lumbar spine holds the majority of the whole body weight, and we see those hernias occurring on a regular basis in a lot of people. For that, we are going to have 5 or 6 slices. It depends on how many lumbar vertebrae our patient has, and we will be slicing them one by one and adjusting our angle, making sure we take in the view the whole vertebrae one by one. We got to be careful because that's where the crosstalk artifact kind of appearing. But this is very important scan, diagnosis scan. With that, saturation band is still there, it's anteriorly. Again, the coronal I'm not planning because my patient is not suffering from scoliosis.